Okay, welcome everybody. A woman I spoke with a few years ago shared that she was postpartum and she called the Yoetzet Halacha, and right after she asked her question and said, I just had a baby and this is my question, the Yoetzet asked, how are you feeling and how are you doing? And she was really touched by that. And in my mind, this really encapsulates the opportunity and, dare I say, responsibility that we have as halachic professionals to make sure that we understand who's asking the question on the other end of the line, what her circumstances are, so that we can most appropriately respond to questions, bearing in mind all the physical and mental health concerns of a woman and a couple. And this time period, the childbearing years, which really can span 20 to 25 years of a woman and a couple's life, has seen tremendous amounts of research in the past decades. And the findings of this research run the gamut from prenatal testing to fertility treatments to how to screen for postpartum depression and how to treat it to what it means to be a good parent. And this is all remarkable and has changed the lives of so many for the better. But the piece where I think we can do better and we can do more, and what I really hope to focus on tonight with our panelists, is some of the scripts that we've written about parenthood, which really starts from even just the idea of having a child and runs all the way through to child rearing. And there are scripts for many different roles. There's pregnant woman should feel, new mom should feel, fill in the blank, my wife should be, fill in the blank, good dad should do, moms should do if they're good moms, and after a miscarriage or a loss, I should feel. And like scripts for many things in our lives, they're helpful for giving us some direction and general contours to go off of, but sometimes the script is not helpful. And one place where the current research and clinical findings that where the clinical research and the current findings really challenge the script is in this area of maternal mental health. And I'm so excited to be joined by two of my colleagues, Dr. Naomi Greenblatt and Deborah Enton, to discuss with them some of the scripts that have been written and perhaps need to be rewritten, drawing on their vast expertise in this burgeoning field of maternal mental health. So welcome, Dr. Greenblatt and Deborah. My first question to you is, one of the biggest takeaways from my work as a Yoetzet is seeing how empowering and how calming it can be when we provide women and couples with knowledge. So Naomi, in that vein, maybe perhaps you can enlighten us so we can understand what is the biology that causes certain mental health challenges to emerge during and after pregnancy.
Well, first of all, thank you so much for having me, and thank you for Nishmat and Mizrahi for holding this amazing conference. I think it's so important both for healthcare professionals as well as for lay people to really become educated on what is a tremendous brave topic. I'm passionate about women's reproductive health. I'm a reproductive psychiatrist, which means I treat only women's emotional health issues across the reproductive lifespan. So what I explain to people is I treat general issues, anxiety, depression, OCD, but I always look at the impact of hormones. So when you ask what's the biology behind postpartum depression or antepartum depression, we have the general biology that impacts women who have a host of issues, which is a neurotransmitter imbalance that typically triggers symptoms. And it could be in serotonin, norepinephrine, dopamine. There are several neurotransmitters that can trigger these symptoms. But for many women, it's the fluctuations in hormones that either exacerbate the underlying condition or trigger an episode, whereas they previously wouldn't have had any. So I think what's important to remember is that these same reproductive years happen to be the years where women would present with symptoms, typically, even if they weren't postpartum. So we're never actually sure until we see the time course of how a woman presents exactly what's going on. But I think it's a combination of some type of neurotransmitter imbalance complicated by hormonal fluctuations, which women go through throughout their natural course of menstrual cycles when they take birth control pills, as Ayoette said. I know Tova's my daughter's Kala teacher. I'm very grateful to her for everything she does. But Kalas do not know when they take birth control to prevent chuppas nida. They're not educated to say, well, if you see that your mood starts to fluctuate, say something to someone, because it could be the hormones are not agreeing with you. So ranging from normal menstrual function to birth control pills to post miscarriage to depression and pregnancy to postpartum depression to perimenopausal issues. So hopefully that's a broad answer, but enough to get us started.
Wait, unmute, Tova. There you go.
Okay, thank you, Naomi, for sharing that with us. It's really important that we understand, and definitely a plug for asking our doctors questions if we don't understand or we feel something that feels off. One of the scripts that is definitely out there is that pregnant women are supposed to be happy and excited, so excited all the time about being pregnant. And when this is not the case, Naomi, from a medical perspective, in your work, and Devorah, from your work as a therapist, what are ways that you help women to deal with this breaking of the script? How do they deal with the fact that they're not feeling what they're supposed to feel?
So I'm happy to start with that. I think one of the things I want to, if I can I just back it up for like one level before? Because I think we want to kind of quantify a little bit about what we're actually talking about from a psychological perspective, from a sociological perspective, and then obviously you've just introduced the idea of a medical Dr. Greenblatt introduced the idea of a medical perspective. I think what's very important for us to know is that we've shifted away from just exclusively talking about postpartum depression, right? If you ask a psychiatrist, if you ask definitely a therapist working in the Jewish community, for sure, do you see more depression? Do you see more anxiety? Most of us therapists are like, oh, for sure, way more anxiety than we see depression. What that tends to what that tends to breed is this kind of, wait, I thought it was supposed to look a specific way, and I just, I'm not depressed in bed, but I don't feel comfortable. There's something kind of going wrong with my feelings. And like Naomi, inferred in terms of that idea of it could be antenatal too. So what we also are understanding is it really isn't exclusively after I give birth. We have women that are starting to say, I didn't feel good in the second trimester. I immediately after getting pregnant, my moods just shifted. Or as the delivery approached, I began to get more and more anxious, more and more struggling with my moods. So we are really looking at this as a perinatal mood and anxiety disorder experience. It's not a spectrum disorder. It's not just like this is the easier version and this is the harder version of it. We are seeing it as very unique facets of kind of the postpartum and perinatal experience. And I think what's just as important to clarify is so often we'll say, I think I have the baby blues and they're 6 months out from delivery. Well, you don't have the baby blues anymore. Now you're looking at something that's something more, probably more pathology, probably something that needs to be addressed either psychiatrically, psychologically, with help, support, whatever. We'll get into some of those things. But to me, one of the primary scripts that we're talking about is kind of what do I do with all these feelings that I have, because I thought it was supposed to be a certain way. I should be, feeling a certain experience. I should be feeling a certain way, and it doesn't line up with the way that I thought and I anticipated feeling. And so just a couple, like a kind of a checkbox of I want to include, I'm not even going to bother with the PowerPoint, just off the cuff, recognizing that we may be looking at anxiety, we may be looking at depression, we may be looking at some OCD, obsessive compulsive traits or experiences for the woman. We may even in a very serious situation be looking at kind of a psychosis, a break from reality, and even things like post-traumatic stress disorder, where a woman had a horrific birth experience and she struggles with how she experiences that in the postpartum. So that's just want to kind of making sure that we're all talking the same language of what are we talking about. And then let's just back that. I'm going to pass that over to Naomi at this point, and I'm happy to follow up after that. So Naomi, just in terms of the scripts that you kind of want to address.
I just want to define for people, and I always say this, baby blues versus postpartum depression. Baby blues typically resolves within 2 weeks. 80% of women experience it. So I like to tell mothers it's more normal than not normal. And it's a little bit of increased sensitivity, tearfulness, perhaps even feeling sad, sometimes maybe even feeling like you don't want to take care of your baby. But it's mild to moderate and resolves within 2 weeks. Anything severe within the first 2 weeks, a mother who's having any harmful thoughts towards herself or her baby, or, anything extreme, a mother who's not eating, not showering, that would not be baby blues, even if it was within the first 2 weeks. Or once it persists beyond 2 weeks, we sometimes watch, but our level of suspicion that this is going to progress to something more becomes high. So I just wanted to define for everyone out there baby blues versus postpartum depression, because I think it's important. And I think while we're working to break the script so that people normalize and understand, and we destigmatize postpartum depression and antepartum depression, on the flip side, I also find in my practice, many people come alarmed and concerned that they have symptoms in pregnancy and postpartum that really fall within the normal spectrum. They're actually not outside the realm of normal. And one of the things that can commonly cause that is the physiologic symptoms of pregnancy that mimic anxiety. So one of my most extreme cases was a woman who came from another psychiatrist in Manhattan on 4 milligrams of Klonopin in her second trimester, which is not a medication that I would love to be giving in pregnancy. And certainly at that dose, the baby would be at risk of withdrawal. And it was her first pregnancy in her 40s. And I said, did anyone explain to you that your uterus presses your diaphragm as you go further along in the pregnancy, and that's what's creating your feeling that you can't breathe? And I was like, shocked. She was like, no. She was a single mother. It was her first pregnancy. Right. And I thought, okay, well, here's what we're going to do. We're going to get you off Klonopin, and you're going to deliver off medication. And she did. So I want to normalize the script, but I also want to normalize that some of the symptoms that mimic anxiety, or even some of the symptoms of pregnancy, like exhaustion, tiredness, are not necessarily symptoms of depression, which is why I think professionals like Devorah and myself, or speaking to your OB, or speaking to a Yoetzet, can really help women try and figure out, how do I know if I should be concerned? Like everything in life, there's a normal gamut that if you fall on either end, you're still within normal. And then there's when you start to step outside of normal.
I would say also in response to that, I think one of the things that's super important to kind of include in that when talking to women about these experiences is that, so it's not just like, oh yeah, everybody experiences a little bit of that. It's what do we need to do to support you as you feel this discomfort as you progress through the pregnancy? So while it might not be kind of requiring medication or therapy necessarily, but if you're feeling agitated, overwhelmed, exhausted, whatever, even those physical symptoms, what do we need to do to help? And I think that that's where some of the rescripting has to happen. This idea of that martyrdom syndrome, that like, I'm going to be really blunt, that like Mishpacha magazine syndrome, which is like a real thing. It's written in the magazine. That's how I'm supposed to prepare my Shavuos table. And I don't have the energy to do something like that, or I feel like I'm less than if I don't fulfill my vision of what it felt like to be a pregnant or postpartum woman, then I feel less than. And so helping us to kind of challenge some of that, to me, some of that is the rescripting as well. How do we challenge that, like, kind of assumption of what motherhood is supposed to look like into what motherhood really is?
Yeah, Devorah, thanks for bringing that up. I want to backpedal a little bit, and then hopefully we can give some practical tips. Maybe you and Naomi can give some tips for that. But just to back up a little to this medication topic that we were talking about, and thanks for clarifying what is like normal, not normal, and when should you be concerned. I'm wondering, when it comes to planning a pregnancy, if there's a known mental health challenge that's already existing, or if a woman in the past, let's say, had depression or anxiety during pregnancy, how do you manage that? How do you plan for, costs and benefits of medication, and how do you help women and couples deal with that? Maybe Naomi, you could share a little bit about that.
If that's okay. I think it's a phenomenal question. And I think it starts, like many things, with, starting a family doesn't start when you decide to start a family. It's the thought process that comes before that, whether it's emotionally, are we ready? Practically, are we ready? And then medically, are we ready? So I think anyone who has a known history or who's currently experiencing symptoms, my ideal situation is when someone does a pre-pregnancy consult. So they come to me and they say, here's my history. Here, I was either on medication, I'm currently on medication, I would like to go off medication. And those are, like, for me, dream consults, because I have the ability to counsel them based on their individual circumstances, which I can't emphasize enough. A few years back, there was an article in the New York Times about how so many women take medication in pregnancy unnecessarily because doctors just continue to prescribe, and it's such a detriment to women's emotional health. And anytime an article like that happens, my phone rings and, oh my goodness, why am I still on medication? And I said, they don't specify over the course of your life, did you have one episode of depression when you were 14 and you were just kept on medication, or have you had 6 episodes, including a hospitalization? And there's no distinguishing between those two scenarios. So I think every woman takes her unique history, both with medication and the severity of her symptoms, and discusses it with her doctor, and really to decide, is this something that we should consider taking you off medication before? In which case it should be done with enough time to observe if she's stable. You shouldn't take someone off medication, have them get pregnant the next month. It happens to be that's approximately 70% of women who discontinue medication in anticipation of pregnancy relapse. Because unless you fit the right parameters, just to discontinue because you don't want to take medication, pregnancy really does put a woman at high risk. So based on her individual circumstances, we would consider risks benefits. My goal in pregnancy is always lowest effective dose. So it's not either I'm on medication or I'm off medication. Sometimes if they're on polypharmacy, which means multiple medications, we'll bring it down to fewer medications. Sometimes it's if they're on one medication, let's see if we could reduce the dose as best we can, and then have you get pregnant on that dose, always knowing that over the course of the pregnancy, we can adjust up or down depending on the circumstances. So I think a couple should approach it really with a pre-pregnancy individual consultation, not an article or a relative saying, when I was pregnant, I went off medicine, it was the best thing ever. Or when I was pregnant, I stayed on medicine and I'm so glad I did, because what that person did is really irrelevant to anybody else. And there's so many classes of medication in psychiatry. There's anti-anxiety, there's antidepressants, there's mood stabilizers, and the level of toxicity in pregnancy can vary depending on the medication, which is another important factor because many people are so afraid of medication in pregnancy. And I certainly am very comfortable working with many medications in pregnancy. So you have to see someone who this is their area of expertise. One additional thing I want to say, because this has been my experience, it's all coming as I'm talking, like, oh, this is so important. Remind women.
So many important things.
No, I love the conversational aspect of this, but I have worked with women who go to OBs, and I respect OBs across the board, but there are different hashkafas in medicine, the same way there are different hashkafas in halacha. And they will walk into a doctor who will say, I will not treat you if you're on medicine. You must get off your medicine. And my answer is that's not the right doctor for you. They could be an
correct.
But I think anybody who's seeing an OB who will say that, and I would say one additional thing. I've had people who have said to me, my OB says I can never have another baby. And then I say, let's discuss that. And I will share with you my favorite, I have like my favorite therapy stories over the years. And after I had my daughter, who's 10 now, I was building my home office and I went tile shopping for my bathroom, and a woman in the tile store, really like Hashem had a plan, I promise you. She came over and she said, oh, your baby's so cute. Oh my goodness, I so want another baby, not Jewish, not religious, from the secular world. And she said, but my doctor said I can't have any more. I have depression and I'm so sad. And I said to her, look, I'm not going to tell you what to do. And you don't have to see me. You could see anyone who does what I do. But please see someone and don't just assume you can. So sure enough, she called me a few months later. And needless to say, she now has like a 9-year-old. My daughter's 10. She has a 9-year-old. And it was the best decision. And I think that's not always the case. For some people, there shouldn't be another baby. But I think it should be discussed in consultation with an OBGYN and a psychiatrist. So I would advise women to really make sure they're talking to the right people.
And a psychiatrist who is extremely skilled and comfortable, like you just said, in treating. And you will meet those people who are not. And it's so crucial that you have the right people attached to that diagnosis. Yeah.
I love that you're talking about this as a couple's decision as opposed to the woman. Something that I find in my work as a yoetzet is obviously I field a lot of questions from women, but I often find that women feel like because they're the ones with the questions and these questions often involve their bodies, it's all on them. And I think it's so important to remember that nida is a couple's mitzvah. A couple's intimate life is not just on the woman. And so too, planning pregnancies, thinking about pregnancies, thinking about medication for a woman is not just the woman's issue, it's a couple's issue. So I love this idea of having a couple consult with you or with a psychologist and with the doctor. I think it's really important. I hope that there's some couples and men in the audience here that this be a joint just to backtrack, Devorah, to something that you mentioned before, or Naomi, I don't remember who mentioned it, that depression doesn't just happen postpartum. Oftentimes we hear a lot about postpartum depression. I actually experienced first trimester depression, but I was the one who diagnosed myself, and it took me about till 20 weeks to figure out what was going on when I started Googling. And I know that for myself, a lot of angst could have been avoided and challenges if I had known such a thing existed. And then postpartum depression was like all the rage, and that was great that it was being talked about. But I know that I'm not alone. So I'm wondering, what are like some red flags that couples should keep in mind if during pregnancy the woman is not super happy? How do we distinguish between, like, you know, just pregnancy is tough and depression?
Who would you like to direct that to? Totally up to you. Okay.
Naomi,
So
either one.
Okay, I'll start.
Yeah.
One of the things I think about also is kind of in addition to what Naomi was just speaking about before in terms of use of medication in pregnancy, I think one of the things that kind of goes into this conversation too is there may be this expectation that especially if somebody who's been on medication before and chooses to go off medication, there really is this kind of pervasive feeling of, I need to white knuckle my way through the pregnancy. We hear the psychiatrists talking about that also. They're like, why do women feel like they need to just bear down and just be really tough, and this is going to be hard, and I'm going to do it because it's
real women, tough
real women.
Yes.
Exactly. Yeah. You know, it's like, I have to show you my mug because it just really speaks to the issue. I'll wipe off the lipstick stain, but can you read that? It says, I am woman, I am invincible, I am exhausted, right? That's just like the assumption is that this is who we are, and that makes us who we are. I think that, and especially when it comes to something like mood management in pregnancy, I just have to, you know, kind of white knuckle my way through it. And instead of saying, I'm in trouble, like I'm having a hard time, you know, some of the symptoms we would be looking at, one of the primary things that I'm always asking about is, tell me about your sleep. I'm not asking her, is she sleeping? I'm saying, tell me about your sleep. What does your sleep look like? And I want to hear how many hours she's sleeping, how many hours in a row is she sleeping. Even if she has other children, or if it is a postpartum experience, I might say, well, how many times a night do you get up to go check on the kids? You know, or not how many times a night are you getting up to go to the bathroom? That's assumed. But how many times in the night do you get up and then your mind just can't quiet down in order to let you go back to sleep? You know, some of that kind of that feeling of things that are outside of the realm of what we want to hear a woman describing in her pregnancy. Those would be some of the concerns that we have. But if she has risk factors in play already, then we should be talking about this, you know, hopefully, I wish, prior to pregnancy. And like Naomi said, in an ideal situation, we do pre-pregnancy consultation. In reality, we end up with the woman who goes, oh my God, I wasn't planning and I got pregnant. Like, how many women do I have that got pregnant on an IUD, on birth control? Not most, trust me, it's pretty effective.
I hear all the stories.
Exactly. Exactly. And you're like, you know, there's a point where I have a woman who's like, listen, if God is going to get me pregnant on an IUD plus birth control, then I must be pregnant with the Messiah. You know, like Mashiach is going to be the one that I'm going to be giving birth to. So there is this sense of like, I ended up here. So knowing the risk factors, primary risk factor is, do you have a history of depression at all? So that's your number one risk factor for having a perinatal mood disorder, a perinatal, you know, depression, anxiety. What did your mother's family what does your family history look like? Do we have a history of bipolar in the family? Do we have a history of like, what about right now? Are you struggling financially? Are you struggling with pandemic? Like, that's going to be, you know, I know the conversation tonight is not focused on COVID, but the women who experience pregnancy and conception during COVID it's like something that is going to have long lasting implications. The isolation, the loneliness, the access to care that they would normally have had, they didn't have. Those are the kind of things that could heighten the risk factors to presentation of illness. So to me, it's about, I wish there was a space in the, you know, it's funny because we talk about this with pregnancy loss and infertility. How much do we teach in college classes, right? There's a part of our education that we want to just be like joyful and happy. It's going to be amazing, right? Like Naomi, you're going to sit there, your daughter is probably like my daughter, which is like, knows way too much about illness. So we're going to be paying for their therapy for the rest of their lives anyway, so it's fine. But like we have really traumatized our children. They know. But the typical normal children who don't have us as mothers, right? They don't know these things. And so do we teach and tell them? Or do we like, just so you know, people do have miscarriages? Or do I do I guide them? So it's a conundrum.
Over the years, like in my college classes, I've included a lot more on intimacy and relationships, but I've also included a little bit on, like, I call it coming attractions. They're not always such fun things, but like things that could come up in your life that you should know about. Because if you don't know that pelvic pain exists, if you don't know that miscarriage exists, if you don't know that any of these things exist, maternal mental health challenges, then it's really very jarring. So I often frame it as, these things might come up for you or for a friend, and if you need any resources, please feel free to reach out. And you know, I think it's important.
I think it's very important. I think what I find is that when we teach it, also as when you begin to teach it and people just begin to learn this language, they begin to identify it elsewhere, and that's where the spread happens. Where people go, I heard about this, I know about this, and teaching it in college classes is a fantastic and important way to start.
So all amazing points. I want to go back, Tova, to your question of like, what are the red flags and how do you know, and I applaud you for sharing your personal experience, because I think that's one of the things that is ultimately going to destigmatize this and make women not be shy to say, well, Tova's really normal. And
well, just full disclosure, I actually wrote about this like 4 years ago, stuck it in a Google Drive, and have not touched it since. So
no, but I think
I'm sharing this. Yeah,
I think when celebrities came forward, like Brooke Shields, who wrote her book, or there's been a whole host of celebrities that really shared their postpartum experiences. I think it destigmatized, these beautiful, put together, successful women. It is truly biochemical. It is a medical disorder. It is, if you have diabetes, you need insulin. If you have a thyroid disorder, you need Synthroid. And if you have postpartum depression, you likely need it to be treated. But I have found in my practice, it's a little bit confusing because a lot of the symptoms of depression overlap with early symptoms of pregnancy. So do you have an appetite change? Are you feeling tired all the time? Are you feeling less motivated? Well, all of them can be confused with symptoms of pregnancy. The most specific symptom, if anybody wants to do a litmus test of is this postpartum depression, there's something called anhedonia, which is inability to enjoy things that used to be pleasurable. So for everyone, that's different. So if it's a woman who loved reading on Shabbos, or if it's someone who loves binge watching Netflix, I don't know if I'm allowed to say that on this.
That's okay. We're being open and honest here. Open and honest. So
all of a sudden she's like, I'm not even interested. Like, don't even bring me the book. Or if it's someone who loves to go out with friends and all of a sudden isn't, and it's not because she's tired. To me, as a psychiatrist, that's always, there are other red flags, but that's the biggest one, because a lot of the other symptoms overlap with symptoms of exhaustion. I mean, pregnancy makes you exhausted. I just don't feel like making dinner for the rest of my kids. It's a little tricky because you be tired. If a pregnant woman is working all day and then coming home and has a house full of kids and is trying to make Yontif, it's understandable that she's tired. So, I think that that's a good point to keep in mind.
Okay, thank you so much for clarifying that. So I want to actually talk a little bit about if we have a friend or a family member who is struggling, whether it be with a maternal mental health challenge, like a diagnosed one, or someone who experienced a loss. What are some ways that we can show up for them beyond just like meals and things like that? Like, what can we do to support our family and friends who are experiencing these struggles in a way that's really meaningful, useful, and imparts empathy?
Yeah, I would say, sure. I think, one of the things that we really already have a lot of that structure already set up in terms of like the meal train, right? It's the meal train that exists in probably almost every community, many communities. It's pretty interesting. Certain Hasidic communities have like other things. There's actually like a community in the Monsey area where the Rebbetzin has arranged that every morning for 3 weeks, somebody delivers breakfast for the mother. And there's another community that they send her a lunch, a packaged lunch gets dropped off. So there's certain like structured experiences that exist here that are fantastic, that don't exist in other communities. What happens next, though, is the challenge, right? So I think that one of the ways that we have to really deeply, authentically show up for other people is to keep on checking in. And it's a little challenging sometimes because you might be the very knowledgeable friend, but not be actually as close as you want to be maybe to this person, or you're not her best friend, but you're noticing a challenge. And I think that kind of approaching her and saying, I care so much about you. I think I can see you're hurting. And I think I want to put like the lost one to the side for now, because that's like almost like a different conversation, but from a mental health conversation, kind of beginning to try to like engage with somebody in terms of how are you doing and how are you really doing. The first question most new moms hear is, oh my gosh, the baby's so cute. How's the baby? How's he sleep? Why aren't we checking in on the moms, right? Newborns have a 2-week postpartum visit. They have 2-week post-birth visit. They have a 1-month post-birth visit. We have a 2-month post-birth visit and a 3 months, 6 months. Mothers are getting 6 weeks if you're lucky. You're getting, which is mostly discussing birth control, right? So why aren't we checking in with the moms, right?
Right.
Check in with her. Okay, my friend, how are you really doing? Tell me what's going on. How are you feeling? How are you coping? What can I do? Can I bring, or just dropping off something? Dropping off a snack is great, but not just checking in at that moment, checking in later. Like do it a month later, do it 6 weeks later, especially if you know she is struggling. What are some of the supports that you can just do? Can you show up with some groceries at the front door to say, hey, by the way, there's groceries on your porch, I'll see you later. Or like, I'm leaving you a cup of Starbucks and I'm good. You don't need to spend time with me with no kind of expectation of relationship. And if it's worrisome, then you have to think about who are my change makers in the community? Who are the influencers? Maybe it's your Yoetzet, right? Who I know she has a relationship with, and I'm like, Tova, I have real concerns. See, if she's engaging with you, I just want you to know this is what I'm saying, not as a therapist, as a friend. Who are my people that I can kind of connect to, the Rebbitzins, the women of the community, or the rabbis of the community? I'm just letting you know I'm really concerned about this person, but I maybe don't feel safe or comfortable enough engaging with her. Those would be some of the things I'd be thinking about.
Great. And what about family members who just might be from like a different era and understanding mental health challenges? Like how do moms who are struggling or parents who are struggling handle it when, you know, they're feeling sad and the mom's like, what do you mean? The baby's so cute. Everything is great. Why are you complaining? You waited so long for the baby. What do we do about that?
Naomi, you must see this a ton, I'm sure.
Yeah, so I'm going to chime in. I mean, we have a term that we use all the time, which is called psychoeducation. It's a really important term. I don't want to minimize it. And at that point, I would invite the family to come in, or I would ask permission to reach out to the family. And I wouldn't blame them. I would educate them. I think it's coming from a well-intentioned place. And
Definitely.
I think from a little bit wishful thinking. Obviously, nobody wants to see their daughter suffering with postpartum depression. Some of it is community pressure. You know, in certain communities, there's a tremendous pressure to nurse. And if the mother has to stop nursing, either because it's too exhausting, there's so many mothers that are so determined to nurse against all odds, meaning the baby's tongue-tied, the baby's not nursing, the mother's exhausted, nobody else can take over. She should be on medication, but doesn't want to take medication because she wants to nurse. And sometimes, you know, I have a motto: better a bottle-fed baby and a happy mom than a breastfed baby and an unhappy mom. Of course, there could be a happy medium where there are many medications you can nurse on, so it's not all black and white. But I think educating families of that this is very real, that your family member, this is not just a little bit of like, just, you know, sometimes you're just snap out of it, like just take a shower or go exercise and you'll feel better. And so we have to explain this is really real. Like they don't want to be feeling this way. It's beyond their control. And you didn't ask about this, but I'm going to address medication and postpartum depression because I think it's an important topic. And I'm framing this in a medical context.
Yeah, thank you.
I'm not a pill pusher. I'm not someone that advocates necessarily for medication as frontline. But when it comes to postpartum depression, I would say 99.9% of the time, I do advocate for medication. And the reason is that postpartum depression will resolve on its own in 12 to 18 months. Okay, 12 to 18 months of losing out on a maternal-child bond, and what happens in a family in that time and what happens in a marriage in that time is unnecessary when there are medications typically that take 4 to 6 weeks to kick in. So that's a reason to start earlier. And if you're working with a psychiatrist that wants to give you more immediate relief, depending on your scenario, there are temporary things that we can give while we're waiting those 4 to 6 weeks. So in my mind, if it's a clear case of postpartum depression, not a gray area where let's see if this resolves, I think people should be open-minded. And again, this is my personal opinion. There might be other people that have different approaches, but I would say the watch and wait isn't always the best approach, because you could watch and wait for 18 months. And I just think it's a lost opportunity to have a phenomenal first year.
And you can really suffer, and you're really suffering. Like, don't forget the suffering piece of it. Like, these women can really be suffering. Can I just add one thing to the idea of like communal pressure as well? Like, for many communities, many of our children are marrying very young, right? We marry off. right? You know which communities I tend to work in, right? We marry off very young. And when you're marrying, when your child is 18, 19, 20, 21, 22, when they hit a struggle that they weren't well prepared for, which most of our 21-year-olds are not, right, they immediately are going to turn to their parents. So it's very common for me to have an intake done with a mother who wants to be on the phone, right? Or with the husband who says, I need my mother-in-law on the call with me when we're dealing with some major, more difficult situation. So as providers, we also have to understand the cultural needs of the community where they're not, the normal thing would be to engage the family. So that's why that psychoeducation piece and engagement of family is actually very critical for some of our very young women who are newly pregnant, newly postpartum. One other thing I do want to bring up, which I think is very crucial in terms of not only the postpartum, let me just address postpartum, but for women who are on medication in pregnancy and doing well and doing stable, the primary kind of guidelines that we're hearing out of Mass General Hospital and Harvard is basically, if you're doing well, you're stable on your meds, stay on your medication, because the risk of untreated depression has a quantifiable risk on the fetus. It's not it's zero risk versus the risk of medication. There's a risk of untreated illness, and there's a risk of risk to medication. And working and understanding those risks and really being able to talk them through from a data perspective with experts, I think is very, very valuable when you're working with people who know their stuff and who know the literature.
And sorry, Tova, can I just chime in?
Yeah, sure. Go ahead. Yeah.
Just because we're talking about medication and pregnancy, and I think one scenario that I hear a lot is a woman who had postpartum depression her first pregnancy. She didn't get treated, but now they're contemplating another pregnancy and they're terrified. And what can we do? And so there are ways, as a reproductive psychiatrist, if she's stable going into pregnancy and I see no need to treat her in pregnancy, I will consider sometimes proactively starting medication around 34 weeks so that it's fully kicked in at the time of delivery. And I've had women that have had exceptional postpartum period. They'll say, I never even thought I could have another baby and not have this happen. And this is where every woman's situation has to be presented to a physician as her individual situation, because we customize care to each particular situation. And that includes psychoeducating families, reaching out to mothers, reaching out to husbands at times. If the husbands are a little bit, many of the husbands I work with are amazing. They're tzaddikim, and many are a little bit checked out and need a wake up call of, you know what, your wife's really not functioning. And a baby nurse, as much as it sounds like a luxury, it is not a luxury. It is a necessity. Either you need to get up for this baby, your mother or your mother-in-law needs to come, or you need to hire someone. And sometimes, so you had asked, what do community members do? And what I would answer to that is talk about the elephant in the room. These are hard conversations to have. Nobody wants to hear you need to see a doctor, you need to get a baby nurse, but sometimes saying it actually alleviates the burden on the couple because they're not having to make that decision. I think sometimes giving them the next step of like, here's what you want to do, can go a long way.
Thank you so much. Go ahead.
Tova, can you also address from a feminine, from an empowered woman space, we need to hear her voice. We need to hear her saying, I'm struggling, I'm not okay. And we need to hear her when she says that. We need to really listen. Yeah. And sometimes that I think that's the kind of the script that I want to change, that a woman can say, I'm not okay. And everybody goes, how can I help you? And let me figure out what pathway you need that's going to work, like you said, tailored to your needs personally and privately, but that we don't minimize that. And we really amplify her voice, and that there's no mitzvah in this suffering. And that's sometimes what we have to talk about.
Yeah, I love this focus on, stating what the woman feels and listening. I think that's so important because, like you mentioned before, Deborah, we have this martyrdom culture, which I think exists as parents and also as observant women. There's so many times where I speak with women about run-of-the-mill needs or questions, whether it be, okay, like I'm asking this question and I have this difficult situation, and then I'll give an answer which might appear to be a kula, which is actually not a kula. It's what the woman should do in that situation. And she'll take it as like, oh, I got a half-baked halachic answer and I should have a lot of guilt. And that's not the answer. The answer is a woman asked a question. She has specific needs. She stated her situation. And the halacha is that she should do whatever is being advised, whether it be reducing number of Badikot after she had a baby because she's been bleeding for 10 weeks, or how to deal with staining because she and her husband have been able to be together for 10 weeks and they just had a miscarriage. So it's so important for us to really listen to women, whether it be contraceptives. I speak with tons of women about contraceptive options, and it seems like a lot of women are given two choices postpartum. You can either have the mini pill or you can have the IUD without some of the color to fill out what they might be signing up for either of these choices, whether it be staining on the mini pill or the IUD 3 to 6 month adjustment phase. I have so many women who are IUD texting buddies every day. What's my status? We really have to listen to women, listen to their concerns, and educate them. So I really think this is a really important takeaway for maternal mental health and in general for working with women. Another area that one of you touched upon before that I'm curious to hear your thoughts on is sometimes the elephant in the room that we talk about when I talk with women is libido during pregnancy and after pregnancy. So a lot of times I hear from women like, so I'm 6 months and I started doing 6 weeks postpartum. I started doing my Badikot, but I'm really not ready to be intimate with my husband. Do I have to go to the mikvah? No. Can I go to the mikvah if I'm not ready to have intercourse? Yes. Do I have to have intercourse on mikvah night? No, not now and not ever. There's never an obligation. I'm curious to hear what's like within the realm of normal in terms of libido during and after pregnancy, and what would be a red flag, and how do we address these issues as they come up from a mental health perspective?
Naomi, why don't you address that from the medical, from the side effects issue?
I'll try and it's a very broad question. I'll try and hit some key bullet points. I never like to use the word normal. It's a problematic term because what's normal for one couple might be not normal for another couple. So one of the things we want to ask is, how are both partners feeling based on their current frequency? Now, if the frequency is 0 for a prolonged period of time, so perhaps we're approaching maybe slightly problematic. But I think that libido is impacted not just by the hormones, but also by the exhaustion, by how overwhelmed a mother's feeling, by her lack of support, by her body image, by her inability to connect with herself. We carry babies for 9 months and then we nurse babies perhaps, or we bottle feed babies, whatever it is, there's a loss of self. And in order to really be present in the bedroom, there has to be a sense of self. So I think in approaching the reason for the low libido, we want to reassure women that it is quite normal, but we also kind of on an individual basis want to understand the reason one woman might be struggling, which is, I hate my body and I can't come to terms with the fact that it changed. And a lot of that is acceptance, embracing, focusing on what you do feel good about. I always tell women lingerie is not just for a man, it's also for a woman. It makes you feel good and it makes you feel attractive. And what you wore when you were a Kala may not be what you wear after baby number 3. And maybe a trip to the store might help. So
some Kalas don't know that you can actually get lingerie like before you get married. So sometimes I tell women like lingerie shopping is not just before the shower, but also for after. That's like education point number 1. And then
that's so funny. Yeah. My old office used to be around the corner from a Victoria's Secret, and I used to say, "Well, should give me commission," because I'd be like, "From here, I'm going to go there," only because it was the closest place. I don't have commission. But I'm like, you're not going to do this for your husband. You're going to do it for yourself because you want to find a way that you can feel good. So, but it depends. Is it a body image issue? Is it a hormonal issue? And birth control can also be a really significant cause of decreased libido that people do not focus on enough. Is it exhaustion? And then we can suggest to the mother, maybe you need to be getting more sleep. So I think we do want to, we want to normalize that it does take time. And, for some women that could be 3 months. For some women, it could be 6 months. And there could be a gradual progression of reclaiming your couplehood. You transition from a couple to a family, and then you have to reclaim the couplehood. The other thing I want to focus on is non-sexual physical touch, which I think is underemphasized in your question that women ask of, can I go to the mikveh and not be intimate? I mean, I'm so glad halakhically the answer is yes, but I tell women all the time, if they feel like their husbands are ignoring them, but then saying like, oh my God, it's been 6 weeks and I can't wait to, like, when are you going to the mikveh? They're resentful, I think, perhaps in some cases, because there hasn't been either that emotional connection or there hasn't been any form of non-sexual physical touch, which there can't be until she goes to the mikvah, but there needs to be that sense of security and safety that gets rebuilt in the marriage before you leap in. So I think understanding the underlying cause will help improve whatever the situation is. And I would tell women, I would stay away from the term normal or not normal. I would say, are you comfortable with where you're at? Is your husband comfortable with where you're at? And if not, what can we do to improve it?
Yeah. I'll go with everything you just said. Love it.
Okay, thank you for clarifying. Okay, so I'll ask you one more question, and then I'm going to open up for the chat for questions, and we'll take some questions from the chat. So if there was one, I would say, takeaway or one script that you'd like to rewrite, or a message to parents or people hoping to become parents, what would it be?
Go ahead, Naomi, you go first.
So I have one. This is like my take-home comment to every mother, not just new parents, medium parents, older parents. I say the strongest muscle in any woman's arm that I work with, but really in any woman's arm, should be the one right here, because every day she should be doing this. And I think that any job that someone works at, if they're not getting feedback from a boss, they're not going to remain motivated or inspired or passionate about what they're doing. But as mothers, or as wives sometimes, there is no one to say, you know, you did a heck of a job today. Like, that was well done. And so if we don't, I call them self-supervisory comments. I literally have women write one self-supervisory comment a day. And it's not for the above and beyond. It's for, I always say, the first day of school doesn't happen without a mother who hemmed pants, bought new school supplies, packed lunches, did hair, brushed teeth, you know, got them to the bus stop, all, you know, sweating probably and not trying to, but put them on the bus, either smiling or maybe not smiling. That's Yasha Koach every single time. And so many women say to me, like, really? Because like my neighbor has 10 kids and she does that. And the one across the street has 6 kids and she does that. And I only have 4. So why should I be Dr. Greenblatt, why should I be doing this? Then I tell them, you know, I do this like every day, and I don't do half of what anyone else does, but I still do this because I know I showed up, I gave it my all, and I was as successful or not successful as that day allowed me to be. So the script I would change is, don't focus on what you're doing wrong. Try and focus on what you're doing right. And I think that goes a long way.
Thanks, Naomi. Devorah, what would you say?
I think I didn't put it as eloquently as that, and I'm going to like take notes and write that down for my own clients. But I think, and for myself, I think it's about like making sure you find your posse. Like, you have to find people in your circle or extended circle or online community. Find your people who you can be more fully vulnerable with. If the neighbor next door has those 10 kids and they all have matching outfits, maybe she's not your person, right? But if the neighbor on the other side of you, maybe she has that one mismatched kid, you're like, she's my person. Or who the lady who shows up at Trader Joe's, you know, with the kid who's wearing a Superman costume, I'm like, you're my person, because your kid refused to put on clothing out of his pajamas today, right? So find your person that you could be fully vulnerable and honest with. It may be a sibling, it may be somebody in your community. And I think when you find that person, first of all, it will potentially allow her to be vulnerable with you as well. And that creates this supportive connection with somebody who probably needs it just as much as you do. There's a wonderful blog called Scary Mommy. Some of us have come across, and it's like, oh, she speaks she speaks my language, right?
Great blog.
It's amazing. And so like, find your person. If it's humorous, find laughter in it, but find your posse, because without it, your world can get really kind of narrow and small, and you begin to not recognize that what you're going through is very normal. And the mother next door is experiencing it too, but you guys aren't talking to each other about it. So the more we connect, and the more we talk, and the more we're open, and the more honest we are in a supportive space, the greater likelihood it is that people will feel better and stronger and connected. And I will say, Naomi, I think I use this with my clients, as I'll say to them, I will find something that I noticed in anything they said every time I talk to them, something that they did well. And I'll say to them, look at what you just did. Wait. They're like running to jump, and then I did this and I did that. Well, one second. Look at what you just accomplished. Can we just stop for a second? You did not yell at your kids on the way to school, and that was something that you were working on. And you did, hello, can we just stop and acknowledge that for a minute? Every person needs that compliment, every human being. You know, I once was with a client on a phone call, a person dealing with tremendous loss, and she was in a tremendously complicated decision-making process that related to palliative care. And I said to her, just because I was feeling it so deeply, and I said, you have such wisdom in the way that you're dealing with an incredibly difficult conversation. And I said other words, and she goes, wait 1 minute. Oh shoot, what did I say? And she goes, I need to get my husband on the phone. And she called her Jungerman husband, who joined us on the phone, you know, the guy who I would never even call by his first name. And she says, say it again. I said, say it again. She goes, yeah, say it again. Because nobody's telling us that we're getting it right. And so if you have a moment with your child, with your daughter-in-law, like, please say it, right? Your son-in-law, Naomi, your future son-in-law, right? Like, say that line that says, hey, you did that. That was beautiful. You did a wonderful job. Or I'm proud of you. Or did you notice how you're so calm? You know, I'll hear my friends on the phone. I'll be like, well, I just want to listen to you because, like, I just learned so much just listening to you not yelling at your children, you know? And so I think that's find your people and find those moments where other people are getting it right, especially in a grocery store, especially in your own family. It builds people up, and we're all better when we hear those people talking to us.
Thank you for your inspirational comments. I wish I was taking notes as well. I'll just add from a Yoetzet perspective, my message would be that postpartum women should try as well as they can to educate themselves before they have a baby about what NIDA observance looks like postpartum. And I would say women and their spouses, and that if something doesn't feel right and something feels off, to reach out, whether to be to your Yoetzet, to your rabbi, to whoever it might be, because there are so many resources like the two of you who can really help when it comes to mental health challenges postpartum. So thank you for sharing your wisdom with us, and we'll take some questions from our audience. I see one question here is, can you speak about other postpartum conditions like OCD or mania? I'll just say that I've worked with a number of women from a Yoetzet perspective on how to manage OCD. But if you could talk a little bit about that emerging postpartum, that would be helpful. Naomi, you want to take that?
Yeah. So I want to say, especially someone who has an underlying condition, be it bipolar disorder or OCD, pregnancy can either exacerbate or diminish it, but postpartum, it's always at risk of being exacerbated. You probably see a lot of OCD related to Taras Mishpacha, Nida, but there are women that can have a lot of OCD around infant care, checking on the baby, which is very common, especially with a first baby, or they can have OCD with kashrus, and it really is debilitating. The level of distress that it can cause, and that's also my threshold for when someone should seek really professional care. If it doesn't cause you distress, or it's not causing your family distress, it might be problematic, and you probably should get help. But if it's at the point that it's really creating distress, definitely it's something that should be treated and can be treated, and definitely is something that could be exacerbated. To speak about bipolar disorder without getting, it's a whole separate topic, but depression is one spectrum. Bipolar disorder is people who can experience depression alternating with either hypomania or mania. And often we tend to talk in destigmatized terms in the Frum community. So people will say, I have ADHD instead of mania, and perhaps it is. My red flag for women, which sometimes can be normal, but is often something to watch out for, is women who go 3 to 5 days postpartum without getting any sleep. They'll say, in the hospital, I was up all night. I was pacing the room. I couldn't sit. And they focus more on the sleep aspect. And it could perhaps only be a sleep issue, but it could be the manifestation of something that might be the beginning of a little bit of hypomania, which the hormonal changes can trigger. And what we want to do in those cases is first get the mother to sleep. Like she should have the nurse on the floor call the OB and say, is there something you can give me to help me sleep? And along those lines, I'll say one other comment, which is no matter what you're experiencing, OCD, depression, or anxiety, sleep is the most protective factor that is within our control. And when you talk about a postpartum mother, sleep is the one factor that often they feel is not in control. So anybody who's high risk, whether it's OCD, bipolar disorder, or depression, and really not functioning, should really consider getting someone to get up for the baby for the safety and protection of her and her family until she starts to feel better. And there's nothing shameful or embarrassing about doing that.
Yeah.
Okay.
I'd like to, can I just add one other thing? Because
Sure.
I think and you and I, we had talked about kind of just raising this as a term. It is something that sometimes women will present with this idea of intrusive thoughts, or we can call them scary thoughts. There's a great book out by Karen Kleinman called Good Moms Have Scary Thoughts. And some of those thoughts can be relating to my baby, like I'm afraid that there's something wrong with my baby. I'm afraid of cutting vegetables near my baby. What if something happens? It can restrict her interactions with the child, and that's what Naomi's talking about in terms of like how is it impacting her and her family. Like I had a mom who said, I can't change the baby's diaper because like what if I molest my child? It can get that severe. And so again, there's no reason for martyrdom. You're in distress, reach out and get help. Is this just like kind of transient thinking that people are like, we all have intrusive thoughts sometimes, like, right? Like drive down the highway with a truck in front of you that's got a 5 different cars piled up. And that thought of like, oh my God, what if that thing comes loose and the trucks come flying off the highway and smash my car and I get killed, right? That's an intrusive thought. And then I say, let me move over to the next lane and then I'm going to get off, like, and then I keep going on my way. Like I'm able to push it out. People that have these intrusive thinking that it can accelerate to a point where it really creates distress and disruption. And that's where we really are encouraging people to reach out and get support and help. That's not psychosis. And I think it's important for us to acknowledge that there are those that do manifest with psychosis. It's rare. It usually is happening within the first couple of days postpartum, where she is losing touch with reality. And it's very important for us to be aware of that, where it's not one of these moments, because we'll hear this, where the mother will be like, snap out of that. What are you doing? Why are you talking that way? You're talking crazy. Those are the kind of things where her behavior is really erratic. That's an emergency. And we really, that's not let me get an appointment in 6 weeks with a psychiatrist. That's let me call her OBGYN, and hopefully that person is knowledgeable enough to say, I think we have a medical emergency here, and we are a little bit more reactive and responsive to that.
Thank you for addressing that. So we're running low on time here. So I wanted to thank both of you really for opening up a conversation about a topic which I think is still very much stigmatized. People talk about infertility a lot. Devorah, you've done a lot of work on that. We could do more, but it's amazing to see what has happened in the past number of years. Postpartum depression, we talk about it, but we don't always share. But things that happen during pregnancy and all the details of the messy postpartum period that can transpire that nobody sees and nobody hears about are really not shared amongst friends. And there's a lot of shame. And I think it's really important that we are normalizing that. Just like when someone has a physical ailment, they go to a doctor. When you have a mental health challenge or a couples challenge, you go get medical and mental health professional help. And I hope that these types of conversations will continue to happen in our community, and that this is the start of more people realizing, I need help, I'm going to reach out to professionals like the two of you. So thank you so much for what you've offered to our global health and halacha world tonight, and I really appreciate it.
And I want to just add one other thing. When you have a Yoetzet Halacha in your community, that's one more advocate. That's one more person that you can turn to. That's one more person who has her finger on the pulse of the women of our community. And that is going to spread this wisdom, right? It's like the spreading of the gospel. Like we can spread the gospel through you, through the other, but it's also takes the women of our community saying, what about you? And what about you? And reducing that stigma this way as well. And these are the conversations that are making it happen. So kol hakavod to you, to Nishmat, to our community, to the founders, to the sponsors, to really to doing something extraordinary.
Thank you.
Thank you, everyone. Have a good evening.
Have a good evening, everyone.
Nice to see you.